For joining today. If you can let me know if you can see the slides, I will begin. So again, thank you for joining You, Me, Sacred Birth, session 7, chapter 7, Holistic Care, Empathy, Humanity, and Dignity. You can also go to www.menti.com and use the code 13412269 and enter the code so that you can participate in today's session. We are also supported by the Educated Birth by founder Cheyenne Varner, where their tagline is "We support you as you support parents with inclusive teaching tools for pregnancy, birth, and postpartum." Again, those are the instructions to participate today in the interactive part of our session, www.menti.com. Enter the code 13412269. I also have it in the chat. And you can also scan the QR code at the top of every slide. You'll also see the same information about how to join and the code if you ever get disconnected. So for those who are present, I usually start off with some interaction around like where people are. And if you want to participate, that's great. If you can use the two-letter state abbreviations to let us know where you are dialing in from today, or not necessarily dialing in, where you calling in or where you are on for virtual participation. Currently, I am normally in Tennessee when I do this, but I'm currently in Washington State. So thank you, folks from California. Great. And I'll just keep going through. So the next question is, I woke up today feeling grateful for, and you can write out full sentences if you want to share what you are grateful for today. I am grateful for my chosen families. And my given family too, but particularly my chosen families here in Seattle, where I'm currently staying in this season of my life. So I'm grateful for that. And just grateful to be alive and in my right mind. And grateful that you all have joined us today. So thank you for responding. You are grateful for peace, health, and family. Excellent. So the next question that I ask is, what is your primary role in your daily work? I just put some 4 common things that are on here. If your role is not listed, that's the part that you will select. But with Mentimeter, it allows for real-time data analysis, visualization, and sharing of the data. So whenever you click your response, it will show up. Right now, I have the data visualized as a bar graph. So thank you for participating, that you are showing up as an administrator. I probably serve all 4 roles. And if somebody's role is not present, then you would have picked my role is not listed. And for that reason, I asked the next question around telling us briefly about your primary role in your work life. And for myself, I serve as I don't even know if I said my name. I'm Dr. Karen Scott. You can call me Scotty, she or hers. I serve as the Chief Black Feminist Physician Scientist, founding CEO and owner of Birth and Culture Rigor. And in my daily work, I am responsible for our day-to-day operations, as well as our contracts and grants and partnerships and collaborations, our engagement activities, advocacy work, all those things that are related to how to better evaluate the quality of childbirth through the perspectives, experiences of Black women, girls, and gender expansive people. And then how do we build the capacity of systems and communities to adopt evidence-based, ethics-based, empathy-based policies, practices, programs, processes, all the things so that, particularly for this community, that we can see, we can reimagine birth and hospital settings in our image. And if we start with the communities most harmed and marginalized by their work, then the solutions that we provide will not only improve the humanity and the dignity of the work for our communities, but for everyone else. So if you want to share a little bit about your primary role in your work, you're more than happy to type out your responses and I'll wait a little bit. Again, thank you for responding. A healthcare administrator at a managed care plan responsible for contract configuration in Northern California. It includes Medi-Cal contracts for doulas and midwives as part of Medi-Cal expansion. Thank you. Thank you. So the next couple of questions are about like why you want to participate today, and then we will move into a couple of questions getting to get a sense of your attitudes and your knowledge around the topic for today, which would be holistic care, focusing on empathy, humanity, and dignity. So we'll start with why are you joining us today? And for me, I am joining because I wanted to um, offer a way to engage the public around my book, around the chapters in the book. So this is part of an 8-part series that's free. It's been happening monthly since March. There are 8 chapters, so it's an 8-part virtual book reading and Q&A discussion series. And again, today is session 7, where we'll feature chapter 7 in the book called Holistic Care, Empathy, Humanity, and Dignity in Blackness. So I'm here as both the host, the facilitator, and the speaker. And I am grateful that you're able to join us as well. If you want to share why you have joined for today. Oh, thank you. Dr. Scott is excellent. I'm a doctoral candidate researching Black birth experiences with the support of doulas. This book affirms my findings thus far, has been a tremendous help. Thank you, thank you, thank you. I always appreciate seeing you present. For those people, so thank you for sharing that. And those who have joined us, I'm going to um, actually, you can see on the, I think, yes, you can see. So we are doing the interactive part of the book reading. If you want to go to menti.com, which is at the top of every slide, where it says join at menti.com and enter that code 13412269. That will allow you to also join in today's discussions. And I'm going to find the text that I created to put in the chat for folks that just says welcome to today, you, me, and Sacred Birth, the virtual book reading and QA series. This is session 7, chapter 7. And I'll put that in the chart now. And there should be information also about how to get your copy of the book during the back to school sale and the code for when that sale ends on October the 5th. And it also provides the link to our Birthing Cultural Rigor YouTube channel. Special shout out to our marketing and tech consultant, Julia Scott, for setting that up for us so that you can review the previous recordings for sessions 1 through 6. So thank you, Zakia. So we'll move to the next one. So, as I do with every chapter, we start off with this kind of collective or community way of gathering your thoughts or perspectives or your attitudes and knowledge around the topics that are discussed in the chapter and that we'll go through today in our brief reading of the section of chapter 7. So if you can think of one word that comes to mind when describing holistic care during childbirth in hospital settings. So again, what one word comes to mind when describing holistic care during childbirth in hospital settings? And with this platform, of course, with one word, that you will provide the data visualization, the real-time data visualization tool will be a word cloud. So As you think of one word, if that word is used more than once in this group, it'll be the center word and the largest word. If other words are used, they will show up in similar sizes based on the number of people or the frequency or the proportion of people who use that word. And if they each have equal votes, they'll both be central and big, which is what we have now. So thank you for your responses around the one word that comes to mind when describing holistic care as cultural and respect. Thank you. So here's an opportunity to use phrases that can be complete sentences or incomplete thoughts, but in your own words, describe the meaning of holistic care during birth for hospital settings. Again, in your own words, describe the meaning of holistic care during birth for Black families. Intentional. And if you want to actually use more than one word, you can. So for this, it's function. We can do real-time data visualization of your phrases. So you don't have to use one word for a word cloud. You can, I believe you can type in multiple phrases and they'll show up on the screen. So if you want to describe more than one, if you want to share your meaning of holistic care beyond one word, you are invited to do so. So thank you for sharing intentional. And then thank you for also sharing that your meaning of holistic care is holding space for the specific family to be present in their experience. Thank you. Does anyone want to add any additional meanings of holistic care during birth for Black families? Anything else you would like for us to consider around your understanding, your interpretation of holistic care during birth for Black families? And if not, I'll keep going. And if I go forward and you want us to go back, just, you can come off of mute or video, or just say, go back, Scotty. So I'll keep us going. Now, here's a statement where I would like to get your either understanding or your knowledge of this, or whether you think this to be true or not. Of course, using a Likert scale and a pie graph. So here's the statement, and then you can choose one of five categories, a response that reflects how you feel about the statement, like the statement that most resonates, excuse me, the response that best matches how you feel about the statement, how you feel or how you think or what you know to be about the statement. So the statement is hospital care. I should say hospital care can be described as standard of care, clinically appropriate, and harmful all at the same time. Again, hospital care can be described as standard of care, clinically appropriate, and harmful all at the same time. Which of these five responses best matches what you think or feel about this statement? You can choose strongly agree, disagree, neither disagree or agree. Excuse all my misspellings right now. Agree or strongly agree. So with the real-time data visualization in a pie chart, you can see that in our group, that one person strongly agrees with this and one person agrees. So if we were to just say agrees, we would have 100% of people agreeing with the statement. So keep this in mind. The next one is an open-ended question again. So you let me know what one word resonates with you when you think about holistic care. You also shared, which was cultural and respect. You also shared your definition of holistic care, such as intentional or helping that family be very present during the experience. Based upon what you shared and also other things that you know, how does holistic care for Black mothers and birthing people show up during hospital births? And I would like for you to focus on empathy, humanity, and dignity in action. So again, we focused on like the meanings of holistic care. And now I would like to um, encourage you to think about the manifestation, right? So we may understand what something means, but it's very important to know how that manifests or how that shows up in care, because that's part of how we measure and monitor and either mitigate harm or facilitate wholeness or helping or support. So, for you all, how does holistic care for Black mothers and birthing people show up during hospital births? And if you can focus on empathy, humanity, and dignity in action, and I believe you can write full sentences for this or phrases. And so, if you are going to provide an example of how it shows up, if you can just specify by saying empathy shows up as, or humanity in holistic care shows up as, or dignity in holistic care shows up as. If you need further prompting, I'm thinking about behavior, language, gestures. Like, how do you know when you are in the hospital setting with Black mothers birthing people and the families chosen and given around them? How do you know that empathy and humanity and dignity is taking place during care provision? What types of things are actually being done or said? What are your thoughts? Anybody? Do we need more prompting? So one example I think about as, I would say, a combination of dignity and humanity in action is when, let's say, a Black mother birthing person shows up into triage. Well, this is during a hospital birth. Let's say just shows up either in triage or they're getting directly admitted for labor. And depending on where the bed is positioned and the station where the nurse is collecting the information, the history taking, my first impression of dignity and humanity in action would be the nurse, independent of their demographics, right? Their age, class, race, gender, sexual orientation, all of that. Just looking eye to eye, but not in an intense way. I would say probably this is what I visualize. The nurse possibly being able to sit down, right? Creating an uneven where the family or birthing person is at a higher level and they're sitting down, not just standing over them, looking them in the eye and asking them, just how would you like for me to refer to you? What name would you like for me to use? What are your pronouns? And instead of just saying like, why are you in the hospital? Um, which is important, I would also ask, what about your prior hospital experiences or your prior birth experience that you hope that we don't recreate and that you hope that we do create and do well in? Meaning, I would want to establish already, what can I not do as a hospital team to further harm or re-traumatize this person? And what can we do as a team to lift them up and make them feel wanted and needed and of value? That's what I would do, as opposed to going through the whole, when did your contractions start? I mean, those things are important, but again, I'm thinking about being holistic and how would humanity and dignity show up. So thank you for responding and writing. As someone wrote, empathy demonstrates active listening to the birthing person with care and concern, respecting their wishes. Humanity shows up when we see them as a person with feelings and not just a patient. Exactly. And thank you for responding for this one as well. Dignity shows up when you respect a person's privacy and concerns. Absolutely. And I would encourage you to even go further, because sometimes people think that they are respecting us and they are also perpetuating racism. So I just always encourage people to be as specific in the language and the behavior, which if you notice, I didn't use the word respect in my description. I focus more on like physically what type of eye contact, what's the position of people's bodies, their elevation. Are we standing over a patient, right? Are we at eye level or sitting beneath at a lower level to prioritize, literally elevate them in the space? And I talked about asking a question as my concern to not recreate trauma in this hospital birth experience. And what could I do to ensure that the person feels whole or more whole this time around, whether it be a repeat, pregnancy or birth or a repeat hospital experience. So I also encourage you to try to describe with more accuracy and precision in your language the actual behavior or the posture or the attitude as opposed to using words like respect. Um, because some people think that they are respecting our communities while at the same time they are actually facilitating harm. Just a little additional thing that as a person who, as a scholar and a scientist, grounded deeply in measurement science, it's just very important to be as specific about language, behavior, attitudes, and not just using words like respect that gets used a lot. And we know that our communities are not being respected. So that what does that respect them actually look like or feels? What does it feel like? So thank you. I think I have one more question. Okay. What steps can Black families of the 98% take to make sure they experience a holistic birth in hospital settings? The 98% are, while the data shows that the largest demographic in choosing community births over hospital births, and community births being births at home or births in birthing centers, which are usually led by midwives, while the largest demographic while all racialized groups showed an increase in choosing community births over hospital births, the largest demographic was Black women. And while those numbers increased across all racialized groups, the number is still only approaching 2%. So only 2% of all births in this country occur in community. So what steps can Black families among the 98%? That doesn't mean 98% of Black families. 90% of all individuals, couples, and families in this country still birth in a hospital, independent of their choice of force or coercion. So what specific steps can Black families of the 98% take to make sure they experience a holistic birth in hospital settings? What are your thoughts around that? Okay, so I'll help with this with time. The obvious, right, that everybody wants us to do is to make sure families get a doula. I agree with that. I wholeheartedly agree with that. But I also don't want to put doulas in harm's way. And I also think it's unfair and immoral and unethical to hold doulas responsible for policing physician nurse behavior because there's a power differential. So I think one step that families can do is to have what I call a sacred birth historian. And I'm making this up. But the seven but I've been thinking about this. Like what would it be like for let me take a step back. What do you call the person in the courtroom? They're not called the recorder. I forget the stenographer. No, is it the stenographer? Well, this is live. So I'm thinking about the person who records and documents what people say, what they're saying. I think families, we should invest in that. Like who can be the hospital birth historian or documentarian that can name the different people that go in and out of the room, their names, their roles, their attitude, their language. If someone is keeping a different type of narrative, not a narrative per se that describes like the sanctity or the spiritual part, the ancestral part of the birth, but the defensive part. Like what does it look like for families to create their own legal document of their own interpretation of the language, behavior, attitudes, and care provision that the hospital is doing? Because right now, patients and families cannot go into the electronic health record to put their contribution, their interpretation of the birth experience. But everyone else can write about them and the health record, and decisions get made right through the health record. It's a legal document. I really would like to build the capacity of patients, couples, caregivers, families, community members to be able to document in their own way what's happening, the who, what, why, and how, and help them to keep a paper trail that they can hold on to. Because sometimes people are not yet ready to hold systems accountable for the harm that occurred because they're still grieving and grieving not just potentially lives lost, but the birth experience, the intention that they desired and deserved is still a grieving process. So that's what I would like for people to do. It may not help for that birth in that moment, but I don't know. I don't know what it will, I don't know how a system, I would imagine that a system would act differently if every family came in with a documentarian. I'm just saying. So thank you for responding, having a birth plan, having a support person as a doula, family friend, a close friend. Yes, and I actually really believe you to remove some of the burden of protection and safety. I think that we may need to start training people to just be historians. Like, what does it look like to have a community historian be present at a birth? And that their whole point is just to document and give that over to the family as their like legal document that serves as a record for them. And if you want to come off of mute, you can if you like. If you want anything to say. Um, yeah, but that's what I've been thinking about in greater detail.
Just
Okay,
thinking like
so
how this
oh yes. Yes.
basic AI thing is in here taking notes, like, someone who's in the room taking notes. That's what I kind of first thing came to mind when you mentioned that, how they're there taking notes the whole entire time.
The entire time, right?
Mhm.
I mean, and everybody has to go, right? Most of the people that are coming into the room, except for environmental and dietary, although we don't know what type of record keeping they have to keep to demonstrate that they right, that they cleaned the room, that they dropped off the meal. But everybody in some way or form or fashion is keeping a record of their behavior to
Mhm.
demonstrate to a supervisor, right, that they've done the job that they have been paid to do. What would it look like to get funders, and particularly insurance companies, to invest in community-led, designed, owned documentarians? Because otherwise, it's always going to be the health record against the patient, caregiver, community, family memory. And people will call that, will say that type of recall bias, right, does not hold the same weight of objectivity or legitimacy compared to the health record, which we know with EHR, people can go back into the EHR over and over again and make edits. But I'm really been sitting a lot with building the capacity of community to be their own form of documentarians, and that be like the gift that we can, a tool, a powerful tool that can take some of the weight of policing the health system that doulas and family members end up doing, that takes away their capacity to be fully present, right, with the family. But that's what I've been thinking about. And I was thinking about calling it a sacred birth historian, but we'll see. But yeah, I think we need to start thinking about those, like those community defined or driven or owned um, communication, information, kind of data infrastructure. Like, how do we get to own our own data and
Yeah,
our
that we
own,
own it. Yeah.
yeah, yeah, and our own interpretation, right? Like, yeah, okay. So the last question is demographic information. It's asking like, what is your racial identity? I do center Blackness, so it's either Black African American, Black multiracial, non-Black multiracial, non-Black. Thank you for responding. The next one is about ethnicity, specifically Hispanic or Latin A. You can continue to respond. And then the other one is about gender. So again, just a survey design, the training that I thought has been to put sensitive information such as race, ethnicity, and gender, sexual orientation at the end of a survey or data collection. Okay, you all. So I'm going to start reading, but does anyone have any thoughts around just that activity? Because I'm going to read for like 20 minutes and then as customary, this slide will be present for you to post your thoughts or your questions or your ideas while I'm reading so that you don't forget and I don't forget, but they can be archived here in real time. But if you don't have any initial questions about the chapter or any reflections about this activity we just did, I will start reading. Okay. All right. So here we go. I am in chapter 7, Holistic Care, Empathy, Humanity, Dignity, and Blackness, and I'm starting on page 239. I think what was missing for me was the afterbirth checkup. So, like I said, they left me pretty much on my own. They didn't do nothing. So they came in the room, they did the morning shift change and asked me questions. And specifically, they asked, are you bleeding? How much are you bleeding? And I told them I wasn't bleeding. For 2 days, I didn't bleed after. It was like, oh, that's a miracle. Everybody bleeds. And I kept telling them I wasn't bleeding. And on the second or that night on the second day, I went to go use the bathroom and blood came out of me. The whole room was covered in blood. And it scared me so bad because it was something that dropped. It was like it was a drop. And there was blood all over the room. And I'm calling the nurse, like, what's going on? She's bleeding. She's bleeding. And that's how the one lady came in and was like, oh, there's where the blood was. She kind of joked, and I'm scared to death. Like I don't know. I'm like, oh my God, like I need to go back to, surgery or what's going on. And she's just like, oh, it's fine. This is what we were looking for all these 3 days. But I'm like, if I'm telling you at least that one day that I haven't bled, wouldn't somebody go up there and check? Something ain't quite right. And they clean, like they had to clean the bed out, the towels. We had to sit outside. We had to sit outside in the hallway for them to clean up. They had towels everywhere. And then they just was like, okay, go take a shower if you can. Do you need help? Okay. And then put a pad on. And that was it. In chapter 2, Dominique, a Black mother in the Oakland focus group, recalled feeling coerced and ultimately forced to undergo a cesarean birth. The obstetric medical industrial complex included making threats to involve CPS and packaging information as part of their communication, consent, and decision making process. By chapter 3, Dominique opened up about the regret, guilt, and worry of restricting her diet and caloric intake due to medical advice, and then having her baby born with neonatal hypoglycemia, or lower than normal blood glucose levels for a newborn. Dominique never questioned her physician's dietary advice, and he never gave her a medical diagnosis to restrict her diet. Furthermore, her physician never took responsibility for the adverse impact of his unsubstantiated medical advice and therapy. The quality of care provided to Dominique did not align with the 6 quality domains as established and defined by the Agency for Healthcare Research and Quality, or ARC, and the National Academy of Medicine. First introduced in Chapter 1: safe, effective, patient centered, timely, efficient, and equitable. Based on Dominique's detailed and graphic description of her afterbirth, she experienced postpartum hemorrhage. She and her newborn survived a birth complicated by a postpartum hemorrhage without the need for the administration of blood products or a blood transfusion, without transfer into the adult intensive without transfer into the adult intensive care unit or surgical or other invasive interventions to control the bleeding or save Dominique's life. From a pure clinical perspective, traditional standards of quality care would prioritize and even celebrate the fact that a Black mother and her baby survived childbirth hospitalization complicated by a postpartum hemorrhage without blood transfusion or any other life saving measures. The absence of a holistic Black woman person focused approach to obstetric care, especially for responding to severe maternal morbidity, including postpartum hemorrhage, creates a culture of harm. The last memory of Dominique's nurse in this very scary situation included an image of a nurse giving orders. Okay, go take a shower if you can. Do you need help? Okay, and then put a pad on. The nurse's bedside manner is methodical and robotic and void of empathy, dignity, and humanity. The nurse and the entire hospital team missed an opportunity to acknowledge and affirm a Black mother's dignity and humanity by emotionally connecting with a Black mother and making space to hold her feelings of living through an obstetric emergency. Although the mechanics of an obstetric emergency may appear routine and common to the bedside postpartum nurse, the phenomenon may be new and unusual to the Black mother. Therefore, one may interpret the nurse's performance as standard, clinically appropriate, and harmful. All three can be true at the same time. In that moment, Dominique was searching for empathy from her postpartum nurse, and the nurse, like many nurses and physicians, failed to meet a Black mother's expectations for empathy after surviving a postpartum hemorrhage that left her own blood covering the entire room. The whole room was covered in blood, and it scared me so bad because it was something that dropped. It was like it was a drop, and there was blood all over the room. And they cleaned. They had to move the bed out and the towels out. We had to sit outside in the hallway for them to clean up. They had towels everywhere. Reading Dominique's deliberate choice of words evoked images of a violent act or a series of violent acts culminating in death, like the scenes from a horror movie or a documentary on war. Instead, Dominique granted us direct access to the story behind the statistic. Survival is merely the floor, and the battle more like war for a sacred birth. The remainder of the conversation between me and Dominique included my inquiry about the additional support and communication offered to Dominique while living through such a terrifying experience, during which time her hospital room looked like a murder scene. Dr. Scott, was there an explanation shared with you as to why for 2 days you didn't see blood, and then at the second day there was all this blood? Did anyone provide any insight? Dominique. They told me they never saw that before, and that, they said after that they're going to check the pad. And if you soak up more than two pads in an hour or less than 3 hours, let them know. That was the only follow up after that. Kiara, I got a question. So when you were bleeding, they didn't change your pad? Because after I had my C-section, you're supposed to bleed. Oh, you didn't bleed at all? Dr. Scott. So for 2 days, there was no bleeding and no one said anything to her. Dominique. I mean, they asked me that night. Dr. Scott. But they didn't respond with, like, that's actually unusual to not bleed when you've had a birth. Dominique. They should have checked. Kiara. I know it's hard for you. Dominique, thank you, Kiara. The absence of a follow up explanation from the postpartum team combined with a callous yet clinically appropriate care provides an accurate snapshot of the impact of obstetric quality in U.S. birthing hospitals. One of many pivotal moments during these transformative healing sessions was the authentic connections being formed in real time between the focus group participants, peer sharing and bonding, and between me and the focus group participants. The demonstration of empathy from a peer participant about the Black mother's experience reveals the profound scarcity of empathy and humanity in the provision of health and human services in U.S. birthing hospitals. In the field of medicine, medical educators and professional organizations recognize the value of empathy in the provision of care as expressed or modeled in behavior by physicians. However, empathy in medical care differs from empathy in everyday life. Outside of medicine, empathy is defined as an affective mode of understanding that involves being moved by another's experiences. In contrast, the medical field defines and expects a form of empathy that maintains fidelity to the medical norms and narratives of objectivity and detachment. One medical professional organization defined clinical empathy as an act of properly acknowledging the emotional state of the mother without experiencing that state itself. An unintended negative structural consequence of the 1999 definition of clinical empathy is the development of a physician workforce that values and prioritizes intellectual or institutional mainstream forms of knowing and knowledge over experiential, emotional, spiritual, and cultural forms of knowing and knowledge. The uptake of intellectual empathy by medical students, resident physicians, medical fellows, and attending physicians requires dismissing what a patient feels, knows, and thinks as substantial forms of knowledge, data, or information. Intellectual empathy then becomes a primary lever that defines and shapes the ethics, leadership, knowledge, science, measurement, selection, and monitoring strategies, quality and accessibility, and levels of community participation and partnership that reproduce and reinforce epistemic injustice, testimonial injustice, and hermeneutical injustice. The 1999 definition of empathy mirrors the definition from the 1950s to the 1960s, in which professional or clinical empathy is viewed as cognitive, detached reasoning that avoids over identifying with patients. Neutral apathy allows for predicting a patient's response to their illness through careful observation without feeling grief, regret, or other challenging emotions. Neutral apathy stems from the writings of Sir William Osler, who argued in 1889 that physicians who successfully neutralize their emotions to a point where they feel nothing or numb in response to patient suffering facilitates the numb physician's capacity to see into and subsequently study the patient's inner life. In 2003, a physician scientist synthesized the various empathy definitions to provide greater insight into the meaning of neutral apathy. They described a visual metaphor of detachment that involves projecting the patient's inner life before the physician's third eye by taking on the positionality of a viewer who stands separate from what they observe in the patient differs from society's meaning of empathy. In the traditional sense, empathy facilitates feeling into or being emotionally moved by another's suffering, which requires emotional attachment. A physician who can correctly view a patient's emotions with detached concern begins as a medical student capable of succeeding in anatomy class during the dissection of a cadaver without disgust. That same level of detached concern, void of emotions, then permits a physician to listen empathically without becoming emotionally involved. Thus, thus the standard of care for professional clinical empathy is neutral empathy. that requires turning off one's own humanity to be able to practice detached concern void of emotions. And returning to the chapter's opening narrative of a Black mother who feared for her life, Dominique, while surviving postpartum hemorrhage, the Black mother was seeking emotional connection and attachment with a postpartum nurse. In maintaining fidelity to professional standards of care, the nurse responded appropriately and accurately. Yet the nurse acted in a manner that reinforced obstetric racism while maintaining the professional standards of care. According to Davis, intentionally causing pain occurs when healthcare professionals fail to appropriately manage pain or alleviate or reduce Black suffering. The failures to respond occur within the context of healthcare professionals holding racialized beliefs about pain immunity and providing care that is void of empathy for Black people's physical suffering. When interpreting the response of postpartum nurses to the Black mother's suffering through and survival beyond postpartum hemorrhage, the postpartum nurse's performance is a manifestation of neutral empathy, which is required to reproduce acts of obstetrical racism. The postpartum nurse is a symptom of a larger systemic and structural problems in medicine and in obstetric care. Neutral empathy values and prioritizes intellectual and institutional knowledge over patient experiential, emotional, cultural, and spiritual knowledge, reinforcing both testimonial and hermeneutical injustice. The accurate and precise practice of neutral empathy in the provision of obstetric care also requires shutting off one's own humanity to be able to actively participate in the violation of Black women's humanity and the perpetuation of Black women's suffering. Ideologies of anti Black racism and misogynoir dating back to antebellum theories and writings from Southern physician scientists, and scientists established that Black people were deserving of chattel slavery given their subhuman and non human characteristics, as discussed in Chapter 1. The denial of Black people's innate worth as human beings or their dignity is both justified and reinforced by anti Black racist and anti Black misogynistic ideologies. The operationalization of 19th century antebellum ideologies about Black women, men, and children, and 20th century definitions of neutral empathy mandates the denial of Black dignity and humanity. Therefore, the system of obstetric care is designated not to facilitate sacred, emancipatory, and liberating births. Instead, the institutionalization, professionalization, and financialization of obstetric care are to maintain hierarchies of human value, knowing and knowledge that favor white femininity and white motherhood when white women serve as the default woman. And the lack of accountability and justice in addressing obstetric quality and patient safety violations persist given the absence of measurement selection and monitoring strategies that capture empathy, humanity, dignity, and racism prior to the development and validation of the first and only patient reported experience measure of obstetric racism, also known as the Prim OB scale. In 2020, I designed and led the Sacred Birth During COVID-19 study to develop and validate the first and only patient and community informed instrument to evaluate obstetric quality of care. And at that time, social networks as one quality domain was the umbrella term used to include kinship ties. The quality domain of social networks was also tethered to the autonomy domain as one combined obstetric quality domain called autonomy and social networks. Subsequent rereadings and preliminary data analysis of the 2019 focus group transcripts led to a renaming of the patient identified quality domains based on the expressions, expectations, and experiences Of 36 Black mothers navigating childbirth within hospitals, Black patient, community, and content experts supported the decision to dissociate social networks from the autonomy domain and rename that domain kinship, the seventh and final domain of the sacred birth framework, where sacred includes both a C and a K. Focus group data from 2019 provided evidence showing how, when, why, and with whom Black mothers created and leveraged different kinship formations and forces to address the other six quality domains in the sacred birth framework. For the first time, the 2020 Sacred Birth During COVID-19 study applied Black women defined frameworks to the evaluation of obstetric quality and patient safety for, by, and with over 900 Black mothers and birthing people as Black women, queer, and non binary patient experts. Black women community experts, Black women content experts, and six non Black allied women content experts. The theorized quality care domains that emerged from the 2019 Black feminist hermeneutic phenomenology of pregnancy, labor, birth, and postpartum in the United States as a Black woman included number one, safety and accountability, which is the S. Number two, autonomy and kinship. Number three, communication and information exchange. Number four, racism. Number five, empathy and humanity. And six, dignity and blackness and holistic care. The validation science yielded three independent yet related scales as part of a suite of instruments named the Patient Reported Experience Measure of Obstetric Racism, also known as the PREM-OB scale suite. Humanity has 31 items measuring safety, accountability, autonomy, communication, and empathy. Kinship, 9 items measuring hospital recognition and involvement of social relationships between birthing people and their child or support system. Racism, 12 items measuring anti-black racist and misogynoir in service provision. We evaluate the association between a non-retained item, meaning that survey question was not found to be validated, so it's non-retained in the scale. We evaluate the association between a non-retained item, evaluating empathy. Again, a survey question that was excluded or removed from the final validated survey after evaluating different psychometric properties of the survey items using item response theory and confirmatory analysis. So I'll do that again. We evaluate the association between a non-retained item, evaluating empathy, and patient-reported experience measures of obstetric racism across three subtypes using the three validated measures. The non-retained item that measures empathy as defined by Black mothers and birthing people and demonstrated by hospital clinicians and staff reads as follows. The hospital made me feel that because my baby and I survived birth, my experiences in labor, birth, and postpartum did not matter. And I will repeat that empathy statement. The hospital made me feel that because my baby and I survived birth, my experiences in labor, birth, and postpartum did not matter. Black mothers and birthing people who agreed or strongly agreed with that non retained empathy item were more likely to experience hospital acts of obstetric racism across all three subtypes, greater than 6 times more likely to experience anti Black racism and misogynoir, approximately 6 times more likely to experience disrupted kinship, and more than 8 times likely to experience dehumanization. Prior to conducting a literature review for existing measures of empathy and humanity or developing de novo survey items, we supported Black mothers to provide shared meanings and measures of empathy and humanity. Black mothers described empathy and humanity as the ability and willingness of hospital clinicians and staff to, number one, understand their feelings as Black women, to enter into and become one with the lived experience of Black women, to feel with Black women navigating U.S. society, and especially U.S. hospitals and health systems during any pregnancy related concern, question, event, condition, or outcome. Number two, to be fully present and truly see, listen, believe, and trust what Black women are saying and feeling about the joys and sufferings of pregnancy, labor, childbirth, postpartum, parenting, lactation, and infant feeding, bonding, and attachment without judgment or a need to control, but rather with genuine curiosity, concern, and compassion. Number three, to recognize the difference between empathy and sympathy, and that empathy involves expressing care and concern for Black women and a desire for their well being without feeling into the emotional world of Black women or feeling sorry for, but rather feeling sorry with. Number four, to treat Black women, Black queer non binary people, Black bodies, Black births, Black babies, Black lives, and their given and chosen kin of Black women and birthing people with tenderness or tender love the Black community so often don't experience within hierarchical systems and structures of power and domination. Number four, practice cultural humility and value, pursue, and prioritize knowledge outside of one's self, discipline, or institutions such as patient, experiential, emotional, spiritual, and cultural knowledge. And number six, there's three parts to number six. Acknowledge, affirm, and amplify the humanity of Black women, Black men, Black girls, Black boys, and Black gender expansive adults, children, and youth throughout the perinatal life course by attempting to understand birthing preparation and planning needs, preferences, priorities, expressions, expectations, and experiences within the context of their whole life history, experience, and cultural, spiritual, mainstream, and experiential knowledge, including prior experiences and interactions with the healthcare system and hospital. Being curious without judgment to discover and understand the care experience aligned or differed from the care expectation and acknowledging, affirming, and amplifying the diverse, inclusive, and expansive breadth and depth of identities, lived experiences, types of expertise, knowledge, wisdom, power, expressions, interests, skills, families, partners, communities, and so on within and across the African diaspora. Black mothers express that empathy shows up in clinical and social interactions, communication, consent, decision making, and documentation of healthcare information in patient handoffs, patient sign-offs, and electronic or paper health records as follows. Empathy and action from partner, family support person. The partner cried when the patient cried. Empathy and action from hospital clinicians and staff. Midwives and nurses step outside of their professional and into the personal, feeling with the patients and community support persons. Empathy in action, supportive, very compassionate, like emotionally available and appropriately responsive to the mother's or father's care. Parental care that nourishes and nurtures. Empathy in action. It looks like a good, thoughtful, mindful, curious, compassionate, concerned, conscientious listener without judgment, retaliation, or exploitation. Absence of empathy in action. Behaviors interpreted as non responsive, void of emotion, harshness, hard heartedness, and hostile. Second guessing patient's request for an epidural or any support or service. Denial of the patient's pain and the patient's capacity, autonomy about what they need and when they need it, and absence of empathy and action, lack of compassion regarding birth expectations and rationale, total disregard, dismissal, and devaluation. Three dominant themes manifested from the meaning making of the quality of empathy as measured by the lived experiences of Black mothers in Oakland and Los Angeles, and their desire for more authentic, empathetic, and humanistic connections with hospital administrators, clinicians, and staff. Demonstration of empathy and humanity, also referred to as humanistic healthcare, violations, protections, and affirmations. racial, ethnic, or social cultural concordance between Black mothers and hospital administrators, clinicians, and support staff, and parent child separation at or after childbirth occurring within the hospital without involvement of family policing systems. Black mothers describe the quality of care in terms of demonstrating the presence or absence of empathy and humanity in the provision of obstetric care. Empathy and humanity in action manifest as genuine and repeated attempts by hospital administrators, clinicians, and staff to understand Black mothers based on their expressions of their expectations and experiences as Black women, both in community and hospital settings. Black mothers expected hospital administrators, clinicians, and staff to see, hear, believe, and trust them by feeling with them and not feeling sorry for them, but feeling with them the multiplicity of ways that Black women show up in the world within the context of their whole lives beyond their bodies and births, leveraging their cultural, spiritual, experiential, and mainstream knowledge. For the purposes of meaning making and knowledge production from Black mothers' expressions, expectations, and experiences of empathy and humanity during childbirth hospitalization in this chapter, I use both new and existing excerpts from focus group dialogues and individual narratives from previous chapters. This chapter demonstrates the absence of a holistic Black woman person focused empathy and humanity framework and praxis in the contemporary professionalization of obstetric care and in the everyday design, delivery, evaluation, and training of obstetric care in the US. In response to 36 Black mothers in Oakland and Los Angeles who experienced at least one live hospital birth from 2017 to 2019, Chapter 7 provides a blueprint for a Black woman person focused model of obstetrics care for immediate adoption by all U.S. birthing hospitals and OBGYN residency and fellowship training programs. The first step toward curating a culture and practice of empathy and humanity in obstetrics care is for hospitals to recruit, develop, and coach a workforce that loves their job and commits to showing up, being both enthusiastic and fully present to do the job. And being fully present, Black mothers expected hospital clinicians and staff who work in the hospital based birth industry to be both competent and compassionate, not only desperate to make ends meet. That came from the Black mothers. According to Imani, during a discussion with me and Simone, and again, these names are aliases. According to Imani, during a discussion with me and Simone during the Oakland focus group, if you're going to be there, love your job and be into your job. Just basically be there. If you're going to have like in those types of jobs, if you're going to have that kind of job where you're working with people with pain medication, you really need to love your job and really do your job the right way. Not just having a paying job and you take a paycheck. Given the ongoing, ubiquitous, and national epidemic of denying, dismissing, and diminishing Black pain and suffering in the emergency department and postpartum units after cesarean births, the public and the profession of obstetrics can no longer deny the power of the medical mob mentality to intentionally cause Black pain or to stand by and do nothing to stop Black suffering as the trifecta of violence in the form of obstetric racism, structural racism, and institutionalized racism, grounded in racialized beliefs about pain immunity in Black bodies, especially Black reproducing bodies. In integrating and synthesizing data from chapter 2 with data from this chapter, one must begin to wonder about the character of people designing, leading, evaluating, and financing the structures and systems in place that allow for the absence of empathy and humanity toward Black and Brown people to permeate, fester, and grow within most areas of medicine and obstetrics. When an entire hospital based on both statistical and clinical significance, responds to evidence of higher patient reported postpartum pain scores from Black and Hispanic postpartum mothers by administering significantly fewer doses of morphine each day during postpartum hospitalization to Hispanic and Black women. The problem is not due to a few bad actors. When an entire health system responds to Black and Hispanic postpartum women with significantly higher patient reported pain scores and lower doses of opioid administration by hospital clinicians and staff during hospitalization by distributing significantly lower numbers of opioid prescriptions to Hispanic and Black women upon discharge in comparison to white postpartum women with lower reported pain scores and higher doses of opioid administration, the entire health system commits culpable negligence. Based on these data, the health system failed Black and Hispanic women, their newborns, their existing children, and their given and chosen kin. Inaction in the face of need is institutionalized racism. Dr. Kamara Phyllis Jones, 2000, American Journal of Public Health, the first page, second column, first paragraph, last sentence. Thus, I use terms such as state sanctioned violence or state sanctioned acts of obstetric racism. At the time of writing this chapter, the profession of obstetrics published an article on the last day of Black Maternal Health Week, April 17, 2024, denouncing the term and denying the existence and evidence of obstetric violence. The silence from the profession of medicine, the specialty of obstetrics and gynecology, and the subspecialty of maternal fetal medicine since April 17, 2024 remains very loud. So that is part of chapter 7, holistic care, empathy, humanity and dignity, and Blackness. What are some of your thoughts? And if you would like to come off of mute, you can, or come off of video. It's up to you. But any thoughts to what you heard that you would like to discuss openly? And if you are talking and I'm not able to hear, yes, Sakia?
It just seems like a lot of this is repetitive, which we already know, right? And we keep hearing the same things over and over and over again. A lot of this sounds like a lot of stuff that I heard, and it's just kind of mind-boggling that we keep seeing the same things repeated, and there are tools and frameworks and things available for use, and they're not being utilized. So all of this is just sounds very familiar. Each time you do a reading, it just sounds so familiar, and it's just astounding.
Yeah, that's how I felt writing it. By the seventh chapter, which there are eight, I decided to not even, I made the decision to, after this part, I only included excerpts about how empathy and humanity and dignity were manifested because I didn't think anybody would finish this chapter or the book if I actually wrote how horrible hospitals behaved. And again, this book is based on experiences of Black women and birthing people who gave birth to a live, child between 2017 and 2019. And there are only so many birthing hospitals in Oakland and Los Angeles. So, and we're going to come up on almost 10 years of their birth experiences, right, in 2017. So I hear you when you say this sounds very familiar because we're in 2025 and the data keeps showing that our lives are not of value, and that the systems and structures are not held accountable. So the question then for me becomes, I wholeheartedly understand the movement, right, to midwife the country, the movement to shift the dominant birth experience from hospital to community. And I'm also saying we cannot leave the 98% behind. So, what can we do as a community? Because we cannot rely on hospitals, insurance companies, even academia in certain spaces or the government to help us. What can we do as a community? Going back to that documentarian, like how can we come together to go from a story to a hospital performance score to a strategy? Because we can have stories which are of value, but unless we can translate them into something that can help us, right, evaluate the performance of a hospital and then disseminate that performance to perhaps insurance companies, to perhaps a class action suit. I don't know. But what we are currently doing is not working because there is no, right? There is no motivation or empathy to end the suffering of Black people. That is a dimension of obstetric racism, intentionally causing pain, and that translation of that in the sacred framework, right, is a violation of safety and accountability, a violation of autonomy, a violation of communication, because they're packaging information in ways that looks like it's something about us that makes us not
Hmm.
responsive to pain, right? Medication, or something about us where we didn't seek, treatment or our pain management options sooner. What I'm trying, we need to mobilize a group of people who don't fear losing anything right now. I'm just going to be really honest because we can't rely on gatekeepers to be our voices because there are some people in systems and structures that are proximal to power that enjoy the power and the benefit and the privilege that they have. So they're not going to really shake up the system. And that's why I keep coming back to what can we do as community, right? To
Right.
be our own documentarians, to be our own hub of data, and that we can translate our stories into scores that we can then say, here is the performance of this hospital compared across cities, counties, states, and regions. And then how do we go from that story score to a strategy? And they become somewhat, intimidated by us and the data that we collect. Those are my thoughts still. But thank you for sharing, Zakiya. I don't know how we can force them to use what frameworks and measurements that we have in place. Um, I don't know if it's through a legislative process or is it through a legal process or it's both. I've definitely have been more on the legal side of it, working with
Hmm.
Elephant Circle and human rights attorneys. I still believe litigation maybe what we have to utilize right now, as well as mobilizing our community to know about these things. And how do we support people to grieve the birth that they did not deserve or desire or dream of without losing the time frame that we need to respond in a legal way because there's only right so, I think a year or so I think after the birth. um Yeah, but these are things that I ponder a lot. But thank you for sharing.
Yeah, I was just when you talk about gatekeeping, I was also thinking like, what does a new group of co-conspirators kind of look like, right? Not the
Mm.
gatekeepers, right? But like you said, legislative people, people in the media, maybe a different group of people we need to come together with, and take a different approach because I agree there is a lot of gatekeeping, and
Mhm.
if you're not in the know or of the popular
Yeah,
group, then you don't get in. So that's what
yeah.
I've been learning over the last couple of months. So like
I
maybe I need
agree.
to look for a different group of people
Yeah, no, for
to work
real.
with.
That's why I moved. That's why I'm very grateful to Anna Delgado, midwife extraordinary, everything else in San Francisco, who was like, you need to meet Idra Lucero, Elephant Circle. So Elephant Circle's become like my sacred um, organizational collaborator, co-conspirator, human rights lawyers, right? Human rights lawyers, reproductive justice centered lawyers, birth justice lawyers. I also believe, art, right? artists, activists. I mean, right, the
Mhm.
way that we reimagine future really has always been through either artistry, right? Artism, I must say this right, artistry, artism and activism. And so I am now in the space where I'm wanting to do more with artists.
Mhm.
Because we're going to need to bring our the social science and the humanities, but also art, whether that be visual based or text based or performance based.
Mhm.
But I think that for me, those are the co-conspirators I'm looking for are the griots, the poets, the artists, the painters, the dancers, because we need a way to um, connect around our humanity. Because of course, as we're seeing with, the current administration, that they're coming for everybody. And so
Right.
how do we connect in the breadth and depth of our humanity and realize that we all can win. We can all be valued, but we have to really protect each other. Like we can't start doing the whole oppression Olympics.
Mhm.
But yeah, I agree. I'm really interested in humanities and art as protests right now with lawyers. That's where I'm feeling, where I'm gonna put my energies. And also community design for like community design led forms of science. Like I do think we have tools, but I think we're gonna have to rely on some of our ancestral practices, right, of what we deemed as valuable data and the ways
Mhm.
in which, right, remember with quilts and braids, like there were things that we did to convey or communicate messages, and I think we're gonna start tapping into those ways.
Yeah, I think we have to look for different ways that are still close to us, but just not what we're used to seeing people
Yeah,
use as a means to, get the message out, right?
yeah,
Yeah, I
absolutely.
appreciate you.
Hey, thank you for showing up. Thank you. I appreciate you. And I don't know how to pronounce your name, so let us know if you want to listen. But I see that you wrote a question around as a future OB-GYN, I fear that strict hospital demands may make me seem unempathetic. How can I stay efficient in residency while still showing patients presence and compassion? I don't know. I'm being honest because you as an OB/GYN, right? We had to learn certain things to be accepted by the system and the structure in order to be promoted and advance and to finish residency, to get your board certification, to be a part of the club. Um, I do think there are ways to be more empathetic and more equity driven where in a market-based health system, in a market-based hospital health system, efficiency, right, drives um, policies and practices. But, there's definitely evidence to where efficiency is not always, being efficient is not always effective if we're looking to be human centered or person focused or to be ethical and empathetic. So, I think it's going to be always a challenge. And I think how you go about in your, like in your cognitive mind, telling yourself that you are essentially like it's a duality. The first thing that comes to mind is like, you study to pass the test. You also study to be an amazing, compassionate bedside physician. And I don't know what the testing is like these days because I did medical school like in the 90s. And so, and did residency in the early 2000s, like 20 something years ago. But I always knew that I was studying to pass an exam, but I was also studying to be a humanistic, compassionate um, physician, and they're not the same thing because the forces that be that designed our field of medicine and the specialty itself, it was not designed to be ethical, empathetic, or equitable, even equal. Um, So what I'm going to say with all honesty is it is going to be a constant battle within, and how will you survive those what's a constant war? How will you navigate each battle? I think it's going to depend on who you surround yourself with as your community, as a place where you feel connected and you feel psychologically safe. It may not be your department, it may not be your program, it may not even be physicians. Physicians are not my safe space. I just had this conversation today with my brother here, my chosen brother. Uh, but with these letters behind my name, that is the identity that people first recognize because of the hierarchy of, professions. But being a physician is not my safe space for how I identify myself because of the tremendous amount of harm, centuries of harm that our profession and our specialty has enacted against multiple communities historically and present day. So for me, it is a grieving process. I started residency in 2002. I am still navigating my grief of becoming an OBGYN as I continue to learn more and more of the horrors that we enact against communities because of our standardization, professionalization, medicalization, pathologization, criminalization, like of bodies, of reproducing bodies, of Black reproducing bodies, of pregnancy, of disease, like all of that. A therapeutic space for me was learning about reproductive justice. I also have begun to look at the early, like 19th century, original Black women physicians, because they are not like the ones of today. Um, but we can talk about this offline. But yeah, I've just been, just reading about like while our original healers, right, were our midwives, um, our Indigenous and Black midwives. I have looked to see who the original Black women physicians were. And for me, that what they did during those time periods, in terms of some of them really being embedded in community, resonate more with me. Like some of them were doing births at home as an OBGYN. They're rolling around in the mid 50s, 60s with the mobile unit for pap smears. And you don't see OBGYNs per se doing that now. We see midwives doing that or community people. But the original Black women OBGYNs were doing that. So I am in a stream of consciousness. It's just difficult. I don't really know how to help you. I know for me, I went to a community-based program. Um, Philosophically, if I had to complete residency, because I'm not independent wealthy, so I had to like get through to get a job. But I know I chose a community-based program so that philosophically I could feel better about doing what I was doing, because I at least was doing it with Black and Brown attending physicians in a community hospital where the minority was the majority. Um, and it felt more like a family. It was only after I left residency as an attending that I see how the truth of who we are as OBGYNs. Get a therapist, extend a lot of grace and gentleness to yourself, and do things to honor your humanity. That's music and art for me. And I have just a lot of chosen family and collaborators who are not in medicine. But that's what's worked for me. And then try to, know what your values are and identify in the future, like which institutions, which people, which leaders in that institution curate a culture of practice that more aligns with your values, so that the trade-off isn't you having to choose between efficiency and empathy. Like that should never be what you have to do. But in certain spaces, that is the trade-off. I would try to find places that are really grounded in community. Um, but if you must be in the academia or be in industry, I would have something on the side so that you get to fulfill those other areas of your life and that you have some balance, and not being a cog in the machine. But I hope that's helpful. It can happen. There are some community based practices, um, They're sexual, reproductive, and perinatal health. They're not run by OBGYNs mostly. So I don't know what you want to do. I would say go work with some midwives and be their OB collaborator. I am an OB collaborator for a Black midwifery run health center in Cleveland. So I do try to lessen the trauma of what my profession does by uplifting other folks. But you can always contact
Thank
me
you
if you
so
want to know more.
much.
You're welcome. How
Yes,
do I
Dr.
say
My name is Wantata Mudise.
it? Tata? Nice to meet you virtually.
Nice to meet you, Dr. Scott. Um, you provided a lot of valuable insights, and I am an IMG currently doing my rotations here, and I'd love to work here. And I'm currently educating myself on
Hmm.
the history of like OBGYNs. I'm currently reading, I think, Birthing Liberation by Sabia Wade. And I just
Hmm.
wanted to know, I guess, how I could be able to, because I also want to get into community-based programs. How can I do that without like as a young person already at the beginning? How do I enter the spaces that I know I want without like having to go through other places that may feel like a trade-off, or like as I'm selling my soul, if that.
Yeah. No, it does. It does. I'm gonna put my email. We're gonna say, can you I'm gonna put my Instagram. I'll put my things. I'm like, oh, my email on here. I'm gonna put my Instagram on in the chat. So I purposely went to so for your IMG. So for residency, I this was a long time ago. This is 2000, 2001. I purposely put my first two programs were community programs. So um and again, the state of our country right now with the what am I trying to say? Like what's the most strongest like the devastation of basically Medicaid. So I believe Medicare funds residency programs in the United States. I think it's Medicare or Medicaid. I think it's Medicare. So I think lots of people are very concerned around the future workforce for medicine. Um, Given that is a big issue, and I would consider community programs. But like I said, I made a list of I read I read like the hospital CEO's message. I read the chair's message. Like I kept trying to find consistencies, right, in the messaging of how they saw the purpose of their health system and their role in it. Um, and I asked different types of questions during my residency interviews because like ethics were so important to me. A philosophy of practice was much more important to me because what we learn, is robotical. It is methodical cookbook. I'm not saying that there is an art and a science, um, but a lot of it is sometimes following protocols and knowing when to utilize the art of it to make certain decisions. But I do think having the leadership that reflects, if not who you are, but your values is very important. And I also would consider, um, right, even now, if you have exposure to go rotate through community like led practices, especially a lot of the midwifery led um, either birthing centers or community health centers. In some states, advanced practice professionals or advanced practice nurses, and which are also midwives, certified nurse midwives, require like an MD collaborator. So, I've always wondered like what would it be like to have like if not a residency training program, but at least an elective for OBGYNs to actually truly authentically learn to collaborate with midwives without any way that is non-judgmental, non-retaliatory, very unapologetic, very collaborative, but that centers a midwifery first model if you're going to be in the United States. Otherwise, I would be like, go to another country. But in this country, I would, if you can choose or have options, choose some places that truly value midwives. And you can tell that by who's in leadership. I mentioned Ana Delgado at the general in San Francisco. Like there are certain places where midwives are in leadership together, co-partnering with physicians, as opposed to just being a little blurb, as a tagline, and they're not actually having much say over the culture of practice and the models of care. Just really try to go beyond people's performative words and ask those difficult questions and frame them as a way of being curious. Like, I'm curious as to your current policy or practice or prior approach or experiences with a midwifery first approach. Oh, a midwifery first approach means like I think there are ways to identify, right, which hospitals are going to be more traumatizing and which programs will be more facilitating in terms of you being a humane, empathetic provider. But it does require a lot of work to identify what that is beyond the flashy, bright lights of, come to our program. But yeah, I'm happy to continue to support however I can. But the fact that you're reading what you're reading and you're attending this puts you far ahead than people who are currently practicing obstetrics and gynecology. So don't underestimate or minimize even what you're doing now to continue to be a more empathetic, humanistic, dignity affirming physician.
Thank you so much. Thank you. And I will definitely contact you because I definitely feel like I do need the guidance that you are already offering to me right now.
Yeah, I put my Instagram tagline on there, but I'm sure you can find me. Just send me a DM on the many places that I'm again with the organization or myself, and we can figure out how we can I can support you. And but like I said, you're already doing the work because you are reading things that many medical students, OBGYN residents, fellows, attendings, specialists are not even reading. So I do want to celebrate you and affirm that you are doing the work even now.
Thank you.
Well, thank you all. We're 10 minutes over. I appreciate you both being with me today. And the last session for this book series, chapter 8, session 8, is actually going to be focused on solutions. Chapter 8 is called Emancipating Black Reproducing Bodies and Black Births, and that'll be the culmination of the You, Me, and Sacred Birth, a virtual book reading and Q&A discussion series will come to an end next month. And if you have some ideas around what you want to see next, please let me know. But I do appreciate both of you all for spending this time with me, and I hope to see you next time. Bye-bye, everybody.